Welcome and thank you for standing by. All participants are on a listen-only mode for the duration of today's session. Today's webinar is being recorded. If you have any objections, you may disconnect at this time. I would now like to turn the call over to your host, Bryce, from the Census Bureau. Bryce, you may begin.
Thanks, Anthony. Hi, everyone. Welcome to the FSRDC presentation series. I am thrilled to have this session today. Really excited about this different format. If you've been at this presentation series in the past, you know that we are looking at something a bit different today. We're having a few technical difficulties, and I apologize for the late start, and Anthony and I will be working on those kind of behind the scenes. So we're going to change the order a little bit than what you see in the flyer. We're going to start with Ji-Ho Kim, who is a PhD student in the Public Administration and International Affairs Department at Syracuse University. And I'll turn the time over to him in just a second. Quick reminder, if you have interest in presenting at the FSRDC presentation series, please reach out to me. I would love to squeeze you in, or reach out to your local RDC administrator and they can put you in touch with me. I also want to announce that we are having the RDC Research Conference in September 12th, September 13th, in Salt Lake City, Utah, at the University of Utah. There will be a call for papers coming out shortly, so keep your eyes on that, and it would be great to see you all in Utah. And also, I want to read the disclaimer before I turn it over to Ji-Ho. The FSRDC presentation series offers a virtual platform for researchers who have conducted research in an FSRDC using Census Bureau data to share their work. Though the Census Bureau received a programmatic benefit from this work, the researchers were neither employed nor funded by the U.S. Census Bureau. The Census Bureau and its partner agencies have reviewed the statistical output contained in these presentations and publications to ensure against any unauthorized disclosure of confidential information. All findings and interpretations of these research results are made exclusively by the researcher or researchers and do not represent the views or positions of the U.S. Census Bureau or our partner agencies or institutions. And finally, as Anthony said, you are in a chat-only mode. If you have questions, we will do a short Q&A at the end of each presentation. Please type your question into the Q&A box, and I will be filtering through those, and I will run the Q&A at the end of the presentation series. So without further ado, I turn it over to Ji-Ho Kim.
All right, thank you. Can everybody hear me well? Great.
Sounds great, Ji-Ho.
Great. So hello everyone, my name is Ji-Ho Kim, and I'm a PhD candidate in public administration at Syracuse University. And also I am an incoming assistant professor at Arizona State University starting this fall. I'm so excited to present my paper to you today, which is titled Collaboration as a Tool for Equity, Reducing Racial and Ethnic Disparities in Healthcare Access. First of all, I wanted to define what I mean by health equity. So health equity is defined as a state where everybody has a fair opportunity to achieve their full health potential. As you might expect from seeing this picture here, health equity is a very complex and multifaceted policy issue with multiple root causes in education, housing, transportation, environment, economy, and more. So this leads to my focus on cross-boundary collaboration as a way to address those intertwined factors. As you all know, collaboration literally means working together to achieve a common purpose. And within the context of public administration research, many scholars often refer to this term called collaborative governance, which is a governing arrangement where diverse actors come together to address a policy issue that cannot be solved easily by a single actor. And here are my two big research questions. First, I ask whether government can use collaborative governance as an effective policy tool for advancing health equity outcomes. And I also explore if those distributional effects of collaboration differ over time or for different subgroups of the target population. The empirical setting that I look at to address my research questions is regional health equity coalitions, or RHCs, in the state of Oregon. According to the state legislation, RHCs are defined as autonomous, community-led, and cross-sectoral collaborative groups that work towards the goal of health equity at these macro levels, like the policy, system, and environmental levels, and they focus on communities of color. And RHCs are mandated and were funded to work together by a state government agency called the Oregon Health Authority, which oversees these RHCs. Within my study period, more than 300 participants are engaged in a total of 7 RHCs that serve 13 Oregon counties. The participants come from diverse sectors spanning the government agencies, the healthcare industry, nonprofit and civic organizations, as well as other policy areas. So what do these RHCs do exactly? First, they conduct community needs assessments through in-depth conversations and interviews with the residents of communities of color, and they call this multicultural storytelling methodology. And based on that dialogue with the residents, they establish strategic plans and what actions to take. For example, one action that emerged was providing healthcare interpretation services and training and certifying those interpreters better in marginalized communities. More fundamentally, the RHCs actively engage residents of color in making policy decisions that affect their lives. So that is to ensure that their voices are heard and have meaningful impacts when the policymakers address priority issue areas through creating or adjusting local policies. And these priority issue areas include disparities in healthcare utilization, reproductive health, mental health, housing issues, food security, and more. So this figure visualizes the years in which the RHCs were established in selected Oregon counties. So there are 4 cohorts that adopted the RHC in years 2010, 11, 14, and 18. The main data set that I use is the Behavioral Risk Factor Surveillance System, or the BRFIS dataset, and I get annual survey data of adults living in Oregon from 2006 to 2020. I chose BRFIS because it is the biggest healthcare survey in the world, and quantitative studies on minorities like mine tend to be data hungry. So the BRFIS data is collected through telephone interviews and it uses a disproportionate stratified sampling design based on geographic units like counties. Also, the BRFIS dataset assigns survey weights to individual respondents based on these demographic characteristics to correct for potential non-coverage and non-response bias. But the county is a restricted variable in the BRFIS dataset, and the county variable is necessary for constructing my key independent variable in this study. So I accessed the restricted dataset at Cornell FSRDC. And county was the farthest or the most granular level of data that I could get, given the data availability. And I used survey questions on 4 different types of healthcare access, which ask whether they had any kind of healthcare coverage, a routine checkup, any one person they think of as their personal doctor, and any time when they needed to see a doctor but couldn't because of cost in the past year. And the main method that I use is difference and differences method with 2 different samples. So the full sample compares the outcomes of 13 ever adopting counties with 20 never adopting counties. And the subsample compares 8 early adopting counties and 5 late adopting counties. So those early adopters adopted the RHC in 2010 and 11, and those late adopters adopted in 2014 and 18. And I limit the data years to pre-2014 years for the subsample. And the reason for adding the subsample is that I expect the early adopters and late adopters to have less systematic differences between each other than the ever adopters versus never adopters. And I use these 2 equations to estimate both average and dynamic effects of collaborative governance with year and county fixed effects. The main dependent variable is healthcare access disparity, which is the difference between the percentage of non-Hispanic whites and the others who have access to each one of the 4 types of healthcare. So for example, if 90% of non-Hispanic whites and 60% of others have health insurance, then the healthcare access disparity for health insurance would be measured as 30%, which is the simple difference. And these are the main results. The bottom line is that collaborative governance promotes health equity, but only in the long run and only for some types of healthcare access. And again, the dependent variable is disparity. So the negative sign here is a good thing because it means that collaborative governance reduces disparity and promotes health equity. On the other hand, the positive sign is not a good thing because it means that CG or collaborative governance aggravates disparity and hurts health equity. Although none of the average effects were statistically significant, Collaborative governance decreases the disparity in financial barriers to visiting a doctor by about 14% after 3 years and about 45% after 4 more years. At the same time, collaborative governance actually increases the disparity in having a personal doctor after 1 year of implementation. However, these coefficients consistently decrease over time if you look at other numbers in these two red boxes. So this could mean that the collaborative outcomes reduce more and more disparities and become more equitable with additional years of implementation, although I don't have enough precision to tell the signs of some numbers in these two red boxes. However, I still have some remaining concerns about my definitive estimators, such as those related to the parallel trans assumption, heterogeneous treatment effects, and possible systematic differences between the treatment and control counties. I will not go into much detail about each one of them for the sake of our time today, but I just wanted to let you know that they're there, and I'm not trying to hide them from you. While the models so far compare the non-Hispanic whites and all the other minorities combined, I can break down the minorities into Black, Asian, Hispanic, and others. And the others group includes Native Americans, Alaska Natives, Pacific Islanders, and multiracial. Unfortunately, the data doesn't provide enough observations for each subgroup to be aggregated at the county level, so I just used the pooled logistic regression at the individual level. So this table tells you whether some subgroups are more disadvantaged than others before CG or collaborative governance. I find that even after controlling for other demographic characteristics, systematic disparities remain. For instance, the Hispanic population is least likely to have health insurance and a personal doctor, and the other group is most likely to have financial barriers to visiting a doctor. For some reason that I don't know, the Black population is most likely to get annual checkups. And this table tells us that the estimated effects of collaborative governance and the likelihood of having a personal doctor is the greatest for Hispanics. And the Hispanics were the most disadvantaged subgroup in terms of personal doctor in the previous slide. And if we interpret this number as the odds ratio, then the estimated effect is about 1/3 greater for Hispanics than for non-Hispanic whites. Okay, so what do these findings mean for researchers and practitioners? First, this study examines the instrumental values of collaboration at the community level, moving beyond more micro or meso levels of analysis we can commonly find in the previous literature on collaboration and empowerment. And second, the findings point to a possibility that collaborative governance achieves socially equitable outcomes for disadvantaged members in our communities. This relationship between collaborative governance and health equity or social equity at large has been theorized a lot before, but to the best of my knowledge, no study has assessed this relationship empirically in a systematic way. Next, for practitioners, the findings highlight the importance of continuing collaborative processes over the long run, rather than trying short-term, one-shot ad hoc collaborations. Lastly, it is important to identify which subgroups are at higher risk than others, and really fine-tune and prioritize our activities and investments towards the most vulnerable population. All right, thank you so much, and I look forward to your questions and comments.
Jiho, thank you very much. That was a fantastic presentation. We are going to try and, if you would give us just a minute, I apologize for this. John, can you hear us?
I hear you.
Oh, there you are. Fantastic. Okay, we've got John. Sorry, we were having issues connecting with John's audio. John, are you good to go next? We kind of went out of order.
Oh, I can go. I hope I can manage to share my screen. Then we're going.
Yeah, let's give that a shot.
Is that it? Is that it?
Looks great. John Logan is a professor of sociology at Brown University, and his talk is titled "Locating Hispanic Americans 1900 to 2020." John, I go ahead and turn it over to you.
Okay, thank you. Let's see if this is. Oh, there. There we are. It was a little slow to react. Well, I'm very happy to have such a wonderful audience today. Usually, you know, I talk to 5 or 10 or 20 people, and a couple hundred is pretty good. I am an urban sociologist, and for a long time, I've been studying residential patterns of different groups, immigrants and African Americans in the United States primarily. And I'm interested in residential segregation because I think it's so closely related to inequalities in all kinds of opportunities related to schooling or environmental quality or health or criminal victimization or just about anything is tied up with neighborhoods. And this particular paper, it's the first time I've been able to talk about Hispanic Americans over a very long time period. I have used data from 1980 about up to the present to talk about lots of different groups in the United States. But I've always been very keen on the possibility that someday I'd be able to reach back into the past and see where the contemporary patterns come from. So that's what I'm going to do today. I'm going to do it very quickly. Let me I'll start my own timer. Sometimes I get excited talking about stuff and take a little extra time. So let me see if I can keep moving. So the, the questions that I'm addressing in this study for Hispanic Americans, there's two kinds of questions, and I don't have much time to deal with either one of them. But the first one is, when did Hispanics make the transition from being a major population group in the rural Southwest, that is rural and Southwest, the original pattern from when the Southwest was Mexican, and that was the origin of most of the Hispanics who were living in the United States in 1900 when this study starts. And so at what point did they start to be a major group in other parts of the country and make the transition from being rural and mostly farm workers to being predominantly living in urban and suburban areas? And that's a big transition, and it did occur. And the other question, which is closer to what I normally study, is to what degree did Hispanics face residential segregation in the urban areas that they eventually were living in? How did that compare to the African American experience? And how did it change over time? And so we know a fair amount about this starting in 1980, when we have full count data for Hispanics, for non-Hispanic Blacks, for non-Hispanic whites, and so on, every decade. And in fact, that's why I was studying Hispanic segregation starting in 1980. The data were available. In the last few years, I've moved very heavily into mapping and tracing the residential patterns of African Americans as far back as 1880 in major American cities. And I've wanted to do the same thing for Hispanics, and now it's possible. First of all, there's public microdata for, I'm going back to 1900 to 1940, and this week, the University of Minnesota is going to be releasing a 1950 100% microdata set. And in these microdata, it's possible to identify who are the Hispanics based on country of birth, parents' country of birth, language spoken at home. There's other identifiers like what is the background of other members of the household, but these are the major ones that can be used. And for the purpose of studying location and segregation, I aggregate data to a unit called the enumeration district, which is similar to a block group today. So that's been available for a while now, except 1950 just now, and I'm not going to tell you anything about 1950. but hopefully very soon I'll be able to add it. And the other source, which turns out to be really crucial, and that's why I'm in this session, is making use of the confidential data in the RDC to get information in 1960 and 1970 when people were identified by race, but public data did not really say much to us at all on a national scale about who were the Hispanics. But in the RDC, there is a data set that includes the language spoken in the home while growing up. And I used that as an indicator of Hispanic background. And I've been able to, it was actually, this is one of the easiest things I've done in the RDC for disclosure, maybe because it's such old data, but I was able to have that disclosed, and we have that for 1960 and 1970 for all EDs in the country for those 2 decades. And that fills a very big hole, a hole that until, well, up to now has been from 1940 to 1980. We really didn't know very much, but this turns out to be a very crucial period in terms of segregation. So very quickly, I want to show you how the Hispanic population changed in the broadest way of thinking about where they lived by region and by urban, rural, suburban location. And I've had to divide these graphs into 2 because the scale changes so radically at a certain point. When we start out with less than 500,000 Hispanics in the United States, and if I count them by millions, I've got a scale from 0 to 9 up to 1970, and after 1970, I've got to get, as you see, all the way up to almost 70 million in 2020. So, but this gives you an idea of not only the growth of the Hispanic population, but where in the country was it? And we all know, more or less, that it was California, Texas. You know, these are the states that had the most Hispanics historically, and they still do. But there is a trend starting around 1940 to have an increase in the Hispanic presence in the Northeast, and that mostly reflects the Puerto Rican migration into the Northeast to New York and New Jersey. And then after 1970, we still see a very great predominance of the West as a share of the total Hispanic population. But in terms of the numbers, we're starting to have millions of Hispanics in other regions of the country. So there's a bit of a spreading out and yet still a very strong concentration. And then a stronger shift, I would say, is the urbanization of Hispanics. I use several categories here of kinds of location. Non-metro rural, that's like rural counties, that's really, really rural, and metropolitan fringe, which means a rural area, a relatively low density area on the edge of a metropolitan county. And you'll see that the blue line and the orange line here up through 1940, those are the 2 that were the largest and growing the most. There was some growth of central city population after 1910. And now we have a real urbanization process. I hope you're seeing my cursor moving. I'm drawing attention to the after 1910, it was the city primarily. And then if I move beyond 1940, suddenly I get this yellow line, which is suburban population. So the suburban Hispanic population caught up with the central city population and now exceeds it for Hispanics, while non-metropolitan rural and metropolitan fringe are left behind in the dust. So this is a very big transition the becoming an urban and a suburban population. And now, given that, now it makes sense to start asking questions about their neighborhoods and their communities that they live in, and to what extent are Hispanics living in the same communities as other groups. So now I'll turn to that question, excuse me, quickly, and this is a little more complicated. By 1930, more than half of Hispanics were living in cities, and I have I can illustrate their residential pattern in 1930. This is the first year that I really am able to do this. In the three largest cities where they were present, for the three cities in which they were present in the largest numbers: Los Angeles on the left, and San Antonio in the middle, and New York, which at that time was primarily Brooklyn and Manhattan, is where they were living. So that's the part that I'm showing here. And is a very strong pattern of segregation. There's areas of Los Angeles here that were more than 50% Hispanic in 1930. They're fairly large areas near the downtown area. And what we know over time is that they were moving from those original settlement neighborhoods to the east and developing new Hispanic neighborhoods, almost suburban neighborhoods in Los Angeles. And the segregation level, using an index of dissimilarity in 1930 for EDs, is 0.64. 0.64 is a very high level of segregation. It really means that there's a whole lot of Hispanics living in a few neighborhoods, and then very large areas of Los Angeles where there really were hardly, is close to zero, actually. So it was very highly segregated as early as 1960. San Antonio is a city where the Hispanic concentration is historically on the west side of the city. It was always on the west side of the city. It's still on the west side of the city, and this area here, this very large area of the city, is over 60% Hispanic. Much of it is 80–90% Hispanic, and in New York, the areas look smaller, but there's actually a larger absolute number of Hispanics in the older neighborhoods of Brooklyn and in the area of New York City, of Manhattan, that came to be known as East Harlem. It had been predominantly Italian and on the western part Jewish in 1910 and 1920, but by 1930, this was a very large concentration of Hispanic population in 1930. And actually, an interesting question is, to what extent did this represent the early migration of Puerto Ricans to New York City? And I haven't looked at that question yet. I'm not sure. Well, I can by country of birth, so I can answer that question. Eventually, it became very Puerto Rican. More recently, it has become more and more Mexican. So that's what segregation looks like on a map. Now I'm going to turn to measures of segregation that you have to use your imagination a little bit more in order to interpret. And as I explained on this slide, I've become interested in segregation not only in terms of what's the level of segregation, how high, are they really, really segregated or not so segregated? Was it rising? Interested, of course, in whether the level of Hispanic white segregation was similar to that of blacks versus whites, and the answer is it had the same trajectory, but it was never as high. But there's another aspect of segregation that I personally think is much more interesting, and it has changed in more dramatic ways over the decades, and that's where there's I think a more interesting story. And that's the question of how it's organized in space. What is the spatial pattern? What is the spatial scale of segregation? And for many of you may not have seen this question raised in this particular way, but I'm sure you're aware of the separation between cities and suburbs. With respect to African Americans, there was a period where the metaphor of the vanilla suburbs and the chocolate city, was used to represent the very great degree to which African Americans were excluded from suburbia, even as suburbans were growing fast. And that is a level of segregation that is different from just segregation between neighborhoods. Segregation between neighborhoods I will refer to as micro-segregation. Well, segregation at a micro-spatial scale. And then there is segregation at a larger scale. And the two scales that are significant and that I'm measuring here are, first of all, the city versus the suburbs. So that continues to be an important distinction. The city offers different opportunities and different kind of lifestyles and so on than the suburbs. And then segregation within the suburbs across places. And there is a long history of concern about exclusionary suburbs. And in this case, it's suburbs that just for some reason, there aren't hardly any Hispanics in any of the neighborhoods in those suburbs, and others that all of the neighborhoods are pretty Hispanic. So that's a different scale of separation. And it's an important one because that separation often results from decisions made by local governments about who do they want in their communities, what kind of housing will we make available in the communities, and this has a pretty direct impact on the racial composition of suburban places. And it also separates Hispanics or Blacks from whites at the level of public schools. So another major concern within suburbia is what's the quality of the school system that you get if you live in the suburbs. So I'm very interested in macro segregation of both of these types. And let me show you how it charts over time. And on these graphs, I have a line for a solid line for Hispanics and a dashed line to show a comparable measure for African Americans. And what these show is not the level of segregation, but how much of the total segregation in metropolitan areas is attributable to the segregation between neighborhoods, between census tracts within the city. Here from this first graph, this is in the city from 1900 to 2020. In 1900, almost all of the segregation that was apparent in the metropolitan areas of the country, it was in the cities, and it was between neighborhoods within the cities, and there wasn't much else to look at. Suburbia began to become a major piece of the action over time, and segregation between neighborhoods in the suburbs over time grew in importance as a share of total segregation. But the real story is, what is it that replaced segregation between neighborhoods within the city over time? And the answer is in this graph on the right-hand side. First of all, the blue lines represent, after 1940, an expansion of the role of segregation between cities and suburbs. And happened for both African Americans and for Hispanics. But you'll see that the dashed line for African Americans got to be much higher than as African Americans were. And it's right in this period, 1940 to 1960 to 1970, that's where that action is. And then segregation between suburban places. That is not neighborhoods within places, but between the whole places themselves. And as you see, that's gone off the roof, and it is actually now the most significant piece of segregation is the piece that's between suburban places. So that's those are the results, and there's a lot that can be said about these results and what's their meaning, why are they important, but they're quite large changes in the spatial pattern of segregation. And thanks to the RDC, I got to say thank you. We've got the data for 1960 and 1970 to fill in that particular crucial time period. So that's it for me. Thank you, everybody.
Thanks, John. I appreciate it. Okay, our last presentation of the day will be by Jan Eberth, who is a professor and chair of health management and policy at Drexel University, and also Alex McLean, who is an associate professor and biostatistician at the University of South Carolina, and they are going to be tag teaming this. So, Jan, I think I turn it over to you first.
Yeah, thank you so much for the warm introduction, and I was really enjoying listening to those previous presentations. So we have a very different presentation topic, so hopefully you've enjoyed the variety today. Alex and I, we are colleagues from my prior appointment at University of South Carolina in the Arnold School of Public Health. I'm now at Drexel University in the Dornsife School of Public Health in the Department of Health Management and Policy. And today we're going to be talking about work we've done together for years on the topic of small area estimation for public health research. And we'll focus on applications that have used restricted data in federal research data centers that can be considered as a template or a pathway for researchers who are interested in studying health behaviors and health outcomes for local areas where data is not traditionally made available. So I'm an epidemiologist and health services researcher, and the type of epidemiology that I've always been particularly drawn to is descriptive epidemiology. There are two different types of epidemiologic work at the least. One is descriptive and one is analytic. And descriptive epidemiology seeks to answer these more descriptive questions like who, what, when, where, and how much of a disease or an outcome is present in a population or in a geographic area. And it's intrinsically tied to surveillance because we don't just want to look at things at one point in time, we want to look at them over time so that we can understand how patterns of health and wellness are changing in the population due to policies or programs that are enacted by our governments and healthcare entities throughout the US and more abroad. I want to point out this really nice commentary that was developed and published in the American Journal of Epidemiology in 2022. Matthew Fox from Boston University and colleagues wrote this commentary to discuss, why epidemiology has tended to focus more on causal methods and really great innovative work in that space, but really left behind traditional descriptive epidemiology in favor of that innovation. And in doing so, we've in some ways lost the ability to more clearly articulate to policymakers and public health programs where we need to allocate funds for programs, where populations are most in need of support. And local area data is very commonly asked for by legislators and other governmental entities so that they can think about how they best use their resources. Problem is, local data is very rarely available because survey data that's collected at the states or at the federal level which is used to create what we call direct estimates. They rarely sample enough people in order for us to create valid, reliable local data. So when you think about sort of representation and measurement, these are key factors. They really matter because we want to provide the best estimates and inferences possible. So to do that, the best case scenario is that we have a census of data. And since I'm speaking in front of the Census Bureau today, I'll say, the decennial census is a great example of that. When we collect information on every single person in an area, we feel confident about the estimates we're putting forward. But when we collect a survey, it adds uncertainty, and we have to think about how we're going to produce data at these local levels where we don't have the precision. So Alex and I have done work together to create what we call model-based small area estimates. And this statistical approach operates on the assumption that areas with the same characteristics, variables that we can model directly, that they will have similar outcomes because of the similar characteristics in those places or in those populations. So statistically, we can borrow information from this population-based or global model to come up with predictions for local areas. Multi-level models have been increasingly used in this space, as well as models that have a spatial component like ICAR models to more accurately model the final estimate and sort of between area variability, and include area level variables, not just individual level variables in the prediction itself. So small area estimation has been used in a variety of population-based surveys that are collected and published by different federal entities on a variety of topics. They're increasingly being used by federal agencies. Here's an example you see on this slide from the National Cancer Institute. They have developed a state cancer profiles website where you can see that they are publishing county level modeled estimates of data like, have you ever had a colorectal cancer screening? Now, the system will not let you draw down to more race or sex specific estimates here. And I think this is in part due to issues with the CIs being the confidence intervals being too wide for them to feel confident in them. But we are able to, at the very least, get this county level data, which has not been produced. If you had not used an SAE model, you could not produce that kind of data. Alex and I have done a lot of research together in both child and adult health outcomes, and this is a sampling of the types of health outcomes we've looked at. We've looked at specific diagnoses like ADHD, autism spectrum disorders. We've looked more at behavioral data like HPV vaccination and tobacco use. We've looked at incidence data like HIV incidence, lung cancer screening behaviors. There's a plethora of things that can be looked at, and we have looked at together in these studies. All of those that are marked by an asterisk required RDC use in order to get access to the confidential geographic identifiers we needed to collect and produce small area estimates. Often, if you're just working with your state may be able to provide you this data and the geographic identifiers with it. You'll likely need a data use agreement to ensure the confidentiality of the data. But for those that are, larger national data sets, an RDC is often a required component. And I'm going to turn it over to Alex to talk more about our methods.
Thanks, Jan. Yeah, my name is Alex McLean again. I'm a biostatistician. And so Jan and I are a team here. She's on the epi side, I'm on the bio side. And both of us have used this data, she said, quite a bit to do this small area estimation. You see some of the things that we've gone through here to go from beginning to end. We have a publication, a white paper that's available on the census website that goes into these details it goes through them in a lot of detail. Some may say excruciating detail, but each one of these things has a lot of steps to it, from getting the data to analyzing the data, on site in the RDC environment. We have some information about that. That does work a little differently than just analyzing data on your computer. And then finally to doing the modeling and getting the estimates. Some of the other papers we have go into the modeling part a little bit more, but that's what I'll be talking about today. Some of the modeling stuff. Here's a look at the what the paper is. This really has a lot of detail on it, and we go through an example with Tourette's. It's actually a state level estimates, which is good for Tourette's because Tourette's has a very low prevalence, but we go through an example there. So please check that out for some of the details. The main steps of the analysis that we go through, we have a modeling step, we have a post stratification step, and then we have a uncertainty estimation step. And this model is going to be child level model, person level model. We're not using area level data. We're using data on the person level, but the areas that these people are in that we're using most of the time are counties. So what we're trying to do is develop county level estimates of some outcome, whether it's obesity, ADHD, whatever it is. The model that we used, you see there, it says a statistical approach, a mixed effects model with random intercept, intrinsic conditional autoregressive, which means it's a spatial model. On the next slide here, we have kind of an overall approach here. We start with modeling the outcome. This is where we're getting some relationship between the covariates that we have and the outcome data. And this is a very, very important point because it gives our model, it gives us some strength. So if we know what the relationship between covariate data and the outcome is, then we can apply that relationship to, for example, anywhere in the United States. So it gives our model a lot of strength so that our model estimates are not just jumping around too much. They're more stable. It gives us some stability. We also have random effects in there, which give our model the flexibility to it. So the estimates can vary a good amount from county to county due to that random effect portion. So what happens is after we model, we end up with an estimate for all strata, and a strata may be just male and female, it may be male and female by race ethnicity categories, but we end up with an estimate for all strata for every county. Now, that's fine, but that's not what we want in the end. So we do something called post-stratification, where we combine those strata-specific estimates together into one estimate using what you see here on the other side, which is a weighted average. To do that, we use census data. Let's go to the next slide here. So here, the blue boxes, you see the data that's coming in. The white boxes, those are more the statistical stuff. So initially what's coming into our model, we have spatial information, we have outcome data, and we have covariate data. Okay, so the outcome data and the covariate data, that gives the model stability, okay? Lowers the variability in our estimates. The spatial data, that's going to give it flexibility. That goes to the random effects, which are estimated in a process called shrinkage. The spatial information, what it does is areas that are closer to each other, we think that their random effects are going to be more similar than areas that are further apart. So the spatial information gives us another way to connect areas, to borrow information from one area to the other. After we have that model, we end up with those strata-specific county estimates. Then we go to the post-stratification step where we take our strata-specific estimates and we combine them together using a weighted average. We also have another process here that is creating uncertainty intervals where we want to estimate the uncertainty in our final county level estimates. We use a process called bootstrapping. And with that, I think I'll give it to Jan. She'll talk about some of the results.
Yeah, we have many different outcomes we could have chosen, but for this analysis, I'm just going to show you two maps because we're really focused not on the inferences and the causal relationships, but more the final estimates when we're doing these type of SAE studies. So here you can see we've estimated the percent of children who are overweight or obese, and that's according to child growth curves. It's not applied from the adult model. And you can see the percentages listed and the color coding where the darker areas are representative of places with higher proportions of children who meet this criteria. And you can, see that at least from a gut check, we know that in the South, for example, there's higher proportions of overweight and obesity. So we do see similarly that the estimates are showing similar patterns where in areas like Mississippi, Alabama, Georgia, Tennessee, along the Appalachian area as well, we see higher rates of children who are overweight or obese. And this map and more information about this method can be found in the study Zagodik et al. In the American Journal of Epidemiology. I show this map because it overlays both the percentage of overweight and obese with the confidence interval width, which is really important because it gives us a sense of the uncertainty in the model estimates that we produced. And one thing I'll draw your attention to are these areas where we have both a high prevalence of overweight and obesity and both a high confidence interval width. That's the sort of a areas to be on the lookout for. So in LA County, for example, we see there's a high proportion of overweight, obese children, but also our confidence interval width is large, which gives us some pause when we're thinking about the certainty of that specific estimate. So our work has shown that some of these indirect estimates are really not as good, and we have wider confidence intervals when the population is more heterogeneous. In essence, the global model, what we created to sort of apply to everyone, doesn't really apply as well in these areas. Small area estimates are really useful to understand which geographic areas or demographic groups need additional programming, resources, policy interventions, etc. But it also tells us where we might, especially the confidence interval width, tells us which geographic areas may need more data collection. We may need to oversample some groups in order to improve the certainty of the estimates, particularly in places that have not just a heterogeneous population, but from a racial ethnic perspective, but also from a socio-demographic, the SES perspective. That's important too. So, because if you compare LA, for example, to an area that is more homogeneous, we find the confidence intervals were a lot smaller. I'll also note that rural areas or places that have smaller populations also had more uncertainty in the confidence intervals. So this is Alex and I's contact information. We welcome anybody who would like to reach out to us. And of course, we'd like to make sure to acknowledge the funding. We had a variety of funding sources for this work, including the Federal Office of Rural Health Policy, NIH, and other funders. So really thankful for that. Our RDC project number is listed as well for those who would like more information. And we'll turn it back to Bryce.
Jan and Alex, thank you so much. That was great. We are at the top of the hour. I will say that there were a few questions about Jiho's contact information, and he put that up there. But in case you missed it, you can check out his website at jiho-kim.com. And I do want to, let's see, we have a couple questions if there is time. One was for Alex, and Alex, I think this is when you were talking about the state level estimates for, I think that's when this was written up about Tourette's. And the question from Clyde is, are there any particular challenges with going with a more granular geographic level, such as census tract?
Yeah, it's a great question, particularly for Tourette's. Tourette's is very, very rare. I don't know the total incident, but it's 1% or lower. So the reason why we went with state level data is to get enough sample size so we could have enough cases in there to reasonably detect any types of trends. If we go with census tract data, we're going to have a smaller sample size, and most census tracts we're not going to have any kids that pop up. So going with census tract information, the real challenge is that we're going to have more sparse data. We're not going to have as big a sample size. A lot of census tracts, we're not going to have any sample size. That happens in counties too. There's some counties where we have 0 kids, or some counties where we have 1 or 2. The more of those you have, the more challenging it gets. So there's a little bit of a trade-off because you have a little more, you have more accurate area level information on the census tract. You know more about where that person lives, but you have more sparse data. So it's a little bit of a trade-off. It's hard to say which is better for every study. It's going to change a little bit. Hope that answers your question.
Yeah, it's great. Thanks, Alex. John, are you still with us? Can you hear us okay?
Here I am. Yeah.
Okay, there you are. Fantastic. One question for you actually I would like to hear the answer to this one as well. How do you differentiate between suburban and metro fringe in your graphs that you presented?
Sure. Well, the easy part is the city versus the rest of a metropolitan county. And the way we distinguish between suburban and metropolitan fringe is based on a characteristic that the University of Minnesota has included in their IPUMS data on whether on what share of the population of an ED is urban as opposed to not urban. And so that's kind of a funny variable, but it's so somebody put it together. It's also turns out to be very highly related to the density of the enumeration district, the population density. So you might just as well say that the metropolitan fringe areas are areas that have a very low density of population. You might think that it's like just the whole outside area, you know, beyond certain distance from the city. But it turns out that the areas that are rural within the metropolitan county and areas that are actually quite developed and have subdivisions and so on, they're a little bit intermixed. So it's not as simple as it might be.
Great. Thank you so much, John. Okay, let me check the Q&A one more time. There's several questions about slides and if the slides will be available. After the session is done, I'll go through the transcript and then this will be posted on the Census Academy website. And if the presenters want to make their slides available, they will be available on that website. So, okay, I want to thank each of you. This has been a great session. Thank you so much for your time. Thank you, attendees, for coming and dedicating some time to this. We really appreciate it. I will leave it at that. If there's, let me just check one more time. Perfect. Okay. Thank you so much. Thank you for attending the FSRDC presentation series. Anthony, I turn it back over to you.
Oh, thank you, Bryce. That concludes today's session. You may disconnect at this time. Have a great afternoon, everyone.